This episode is brought to you by podiatrygrowth.com/podpatrol.
So for the Pod Patrol listeners, what should they do to take advantage of the assistance that you can provide?
I worked with Jeff here to create a 5-day email course talking about 5 different systems that are going to help you drill down on what's important as far as gaining new patients. And if people enjoy that, I always have the option of 30-minute free strategy session where we kind of go over what people's current challenges are.
So a 5-email introductory course. That sounds expensive. What are we paying for that? $1,000, $10,000? What are people going to expect to pay for that introductory course for them?
Yeah, this is a free gift to my colleagues. Just gives you an opportunity to do a bit of a self-assessment.
If anyone's interested in more information, they can go to podiatrygrowth.com/podpatrol.
Podiatrygrowth.com. Every step matters. Pod Patrol. Pod Patrol. Pod Patrol. Every step matters. Feet hit the ground, we rise, we climb. Ain't stopping now, it's our time to shine. Turn it up loud. Pod Patrol. Pod Patrol. Pod Patrol. Pod Patrol. Every step matters.
All right, welcome back to Paw Patrol with your host, Dr. Jeff Dikis. Tonight I'm joined by Megan McClellan, the APMA CEO. Thank you so much for joining me tonight.
Thank you, Dr. Dikis, for having me. I appreciate being here and looking forward to the conversation.
Absolutely. I think it's going to be fun. It's going to give people kind of a peek behind the curtains. I know you've been on multiple episodes of Dean's Chat, and I'm sure people have heard those. But for anyone who may have not heard those episodes or aren't aware of you, we want to give a quick background on who you are and how you got to be in the position that you're currently in.
Sure. So I came to APMA as CEO about almost a year and a half ago. But prior to that, I've been in hospital administration association work for the last almost 20 years. So I did most of my work at the Maryland Hospital Association. So we would do the same type of stuff we do for podiatric medicine at APMA, but on the behalf of the hospitals in the state of Maryland. So doing a lot of work related to finance, quality, advocacy, all those type of things. And so my real passion, I guess, in my life has kind of been related to healthcare and service. I'm a military brat to start. So I kind of came into the world of trying to do something that makes a difference. And I think that what we do with APMA and kind of in healthcare is really changing the way that we interact with our patients and be able to advocate on their behalf. So that's kind of been where I started into the association world. And I just love it. And I'm loving being at APMA.
Great. And so far, I've been very impressed with the things that you're doing, and we'll kind of jump into that. But that's a big task, and that's kind of a right-hand turn, off the beaten path, maybe a little bit from what you were doing before, even though it was in hospital and advocacy in the same avenues, but jumping directly into podiatry. What drew you to that when maybe the job caught your eye, or what made you decide to even consider it?
Yeah. So my kind of first look at it when it came across my desk was really the idea of doing something on a national level, because as a national organization, we can really set the tone for healthcare in a different way than when you're working with individual states. And obviously with APMA, we work directly with our state components. So you can still do that state work, but really try to do it on a broader scale. But the idea of working with podiatric physicians and working with a professional group like that was appealing to me, because I think if we can change the outcomes for the providers that are actually providing the care to our patients, then we can actually help our patients even more. The hospitals obviously are huge parts of that, and our podiatrists work within those hospital systems. But to be able to see it from the side of the provider and really how we can make those impacts bigger was really what was appealing to me. And that's been what's been exciting when I've come over, to be able to help podiatric physicians to really do the most that they can. What you all do right now is so needed in our society, and it's getting even more needed as we move forward with, diabetic wound and sports medicine and surgery. All the things that you are doing, that's not going away. And we need to make sure that access is available to our patients and be able to help them.
Absolutely. Correct me if I'm wrong, but you are the first non-podiatrist to lead the organization. Is that correct? What was the I know it wasn't your decision to do that because you got hired, but what was the thought process behind bringing in maybe an outside non-physician voice to be the leader?
Yeah, so it wasn't my idea, but I think it was a good one. So I can say that. And I think part of it is, I think bringing in outside views, when you're running an association, it's not just about knowing what you all do, but it's knowing how to run an association, a business, how to do advocacy. And sometimes those things are built in different areas. And so I think what I was able to bring in was a lot of new perspective on how we are seen, even in the whole healthcare ecosystem, right? So you get to be able to say, I can say to them that I've been working in hospitals, for over 20 years. And our hospital colleagues don't understand the value of what you all do. And that having that perspective and being able to bring that in, I think is different. And I do think the business side of what I have done in the past is able to kind of focus our initiatives and be able to kind of really look at how the organization can be most effective to get the work done for you all. So we were really able to look at like revamping our advocacy strategy so that we could be more effective, even looking at internal operations to bring those forward into 2025 and forward. So I think it was an opportunity. I also think I get to be there because I don't have any skin in the game personally, right? When as a non-podiatrist. So when we do have disagreements within the field, it's not because I, am board certified one place or another, or I went to this school or that school. I'm really just looking at to what's the best thing for podiatry. How do we hear the voices from all our stakeholders so that we can drive towards that true north? So I think it gives me a little bit more objectivity related to it. Not that anybody else was biased prior, but I just don't have that kind of innate thing that how I practiced or how I did something. So I think it allows me to kind of take a broader view and allows the association to take that broader view and bring in some techniques from the type of background I have versus a clinical background.
Yeah, I 100% agree with you because as physicians, we don't spend a whole lot of time on business and running organizations, and someone who has experience in that is going to do a better job at that thing. Not that they can't learn, but I think it's hard for a physician to do those extra things without the baseline training and understanding, whether it be an MBA or whatever the training that goes along with that. Not to say a podiatrist can't go back and get their MBA. My wife just went back and got her master's in higher education. But I think you bring up some really good points there in terms of not having any inherent bias. Like you said, if there's a disagreement in the organization, and I think sometimes any of the naysayers do draw on that. Well, of course, such and such is looking out for such and such because they went to school together or they're buddies or they lecture together or whatever it may be. And you can't really argue against that. Well, yeah, that is true. But having someone in position of power who does not have any of those inherent biases, I think is a benefit, obviously. So you bring up some really good points there. And I completely agree with you that having a quote unquote outsider in there is better than the alternative.
And I think for me, it's like I'm inquisitive, right? Like I'm still learning. My joke is that I just want to be able to play a podiatrist on TV, not actually to go perform the surgeries that you all do. But what it allows me to do is dissect the problem differently because I can say, well, why have we done it that way? Well,
Yeah.
I don't have that history so that I can kind of say, well, have we thought about doing this? And a lot of times people say, yeah, we tried that. That didn't work, but maybe we could try this now. So I think it just gives you that kind of different problem solving technique that you can come in with because I don't have 20 years of history with everybody.
Right. I think that's been helpful and will continue to be helpful. We talk a lot about advocacy. One of the things that I'm not saying you do this, but one of the things I don't like in general is that when people just say words, but they don't actually give me targeted things or bullet points. It's easy. And the people who are the biggest offenders are politicians or say like, we're going to lower taxes. Like, okay, well, that sounds fantastic. But okay, on an actual scale, what are you going to do? Because if you're going to lower taxes over here, you're going to have to do something else to pay for that. It's easy to say the overarching thing without giving any detail. So when we say advocacy, what does that actually mean in the realm of podiatry? Who are we advocating to? What are we advocating for?
Yeah, so I could give you a couple of recent examples, and then if there's other things that you are interested in, I can go into it. So just before the holidays, we were meeting with CMS to talk about the regulatory burden related to the multiple sign-offs that are needed for therapeutic diabetic shoes. You all should be able to do this without having to go back 5 times and get
Yeah.
signatures for it, and really being in the room with the administrators to say, listen, in the world of the funnel, if there's 100 people that need these shoes, by the time you go all the way down this funnel, we are now having maybe 10% of those people getting those. And as a result, you're going to have higher amputations, more complications. You're going to have the things we do not want, which is going to cost more to the system. So we were doing that with CMS, just 2 weeks ago, who are now coming back to us, and we're having questions in that conversation. So hopefully the end result is that we can remove some of that regulatory burden. So that's like the regulatory side of the advocacy that we do. And we do that on many different things that are coming out, the skin substitutes that have been happening lately, those type of
Yeah.
stuff. I think on the Hill, like when we go up to Capitol Hill, we've had over 100 visits with staffers and with Congress people this year alone. And part of it is we need to make sure that when they're thinking about doing things related to changing healthcare, a lot of times they're writing things in for physicians. And sometimes they write it in super specifically to say MDs and DOs. Well, we now have their ear where we're saying when you think MD/DO, you need to think DPM. And we're
Yeah.
up there talking about how the training and education is this, essentially the same with our residency programs and things like that now. And we're in there. So when that legislation gets put in, we're not left out then, right? Or we're not unintentionally left out of something
Yeah.
that shouldn't have been there. And that we need to work on. So those are kind of some of the things that we've been doing recently. So we were on the Hill recently we brought our board in and our emerging leaders program in, because there is nothing better than bringing you all in with us so they can hear about your patient interactions and things like that. Talking about the diabetic shoes, talking about the physician fee schedules, talking about how we need to make sure that we maintain access for care in these communities. And it's really powerful. The hard part about advocacy is it can feel ethereal to people. Where it's not ethereal is recently when we got the Optum decision reversed, when Optum misclassified podiatrists, not as physicians. We were able to mobilize the field. We were working with them with their lobbyists. We were working with them with letter writing. We were getting other people involved. And that decision was reversed in less than 2 months. So those are the things where have real life impact. Or when we got E&M codes for 4 and 5 for podiatry, that's thousands of dollars in pockets for podiatrists so they can now bill those codes. So I think you're right. We need to get better at being specific, because it's not just that Megan is on LinkedIn with a picture next to a congressperson. That's not what it's about. But you have to be in the room to make a difference. And we're in those rooms and doing that every day.
Yeah, I think advocacy as an overarching theme is super important, and it's what kind of protects us. Or I kind of think of APMA as the guard dog. Obviously, I've had Dr. Dahir upcoming, whatever, APMA
Soon to be president, and
yeah,
president-elect.
Pres-elect. And we've talked about that a little bit, but they kind of take care of the things behind the scenes that you mentioned there. So I think it's important for people to hear those things and understand those things. That when we say advocacy, we're not just saying advocacy. We're actually on the ground. We're actually doing these things that are making a difference. I didn't go to Capitol Hill, but I will benefit from the level 4 and level 5. I'm not talking to anybody, but I will benefit from an ease standpoint when I can then turn around and write the prescription to get my patients the diabetic shoes and inserts that they need, instead of jumping through 5 hoops to try to get all this paperwork signed. So I think it's important. I just wanted to kind of touch on that and let people kind of see behind the curtain and see what the actual things that are going on, because I think they gloss over that. Like, well, what does APMA even do? Well, and it's easy to say that, but if you don't know what the actual things that they're doing, you may not think that it's all that important, but in my mind, it's extremely important. Speaking of advocacy, what are some things that people can do locally? I'm just show up, get my kids on the bus, go off to work, and come home and help my wife make dinner. What can I actually do to advocate for podiatry locally, if anything?
Well, I first encourage you to interact with your state components because they're doing a lot on the ground in the states. They do their own Hill days, but on the state capital to go in and make sure that if there's any issues related to scope or licensure, there's a lot of things on a national level we don't have, right? So those decisions have to be made on a state level. So really getting involved on that state level and making sure that you understand what we're doing. A great example of that recently was in New York, where they've been fighting for additional scope there for years, and they won it this year. They got
Mhm.
it for their members because people were actively going in and doing the work that they needed to do to make sure that people knew who they were and the value of that, being able to do that. So I think getting involved with your state components is a big part of that. But what we're also helping everybody learn how to do, if they haven't done it already, your state and federal representatives love coming to see you guys. Invite them to your offices. They'll come. When the federal folks are back in district, we want to make sure that they come by and see you and they see the work you're doing. You do those visits and ask them, and they will make sure they stop by because you are constituents. The thing that we always do, and the reason we love it when you all come to the Hill with us, is we can advocate for you, but you want to see a legislator's face light up, bring them somebody from their district who votes for them, because what they
Mhm.
need are those votes, right? And
Yeah.
so if they know who you are and they know that you're a proponent for them, when we come to say, hey, there's a bad bill in front of you, they already know Dr. Dikis had us over to his clinic. He's a good guy. We have a connection with him. People want to help people they know. So you can do that fairly simple. I think people think it's harder than it is. Call their offices. We can help. Reach out to us and we'll get you connected if you want. The state components can, but they really do want to do that so that when we want to change things, that they're there and they're champions for us that we can then use in the future.
Absolutely. I want to change gears a little bit and talk about your perspective. And this is one of my soapbox things. So I'll let you give your opinion and I'll try not to skew your opinion.
I have a soapbox for everything, so hit me with it.
Perfect. So, one of the things in our profession that I've always found interesting is that some people call themselves podiatrists and some people call themselves a foot and ankle surgeon and refuse to use the word podiatry. Were you aware of that before you took this job? And what are your thoughts on the nature of the two different schools of thought there?
I was not aware of it before I took the job, of the kind of how people are describing it, but I do have a very distinct thought on it now that I'm in it. So I think people should call themselves whatever they want. Where I think we get problems of how we continue to grow and brand the profession, if we don't use the words in some way, podiatric or podiatry, if somebody's looking and seeing what you're doing and goes, hey, I'm a kid thinking about going to medical school and I want to do this, I want to be a foot and ankle surgeon, they might not think about going to podiatric medical school. And we have a real issue right now with our enrollment numbers and bringing students in. And my argument in general, and nobody's going to be surprised when they hear me say this again, is that it's because people don't know who you are, right? Because we have to be saying podiatrist, podiatric physician, podiatric surgeon, so that they know that that is the person who does these things. You're also foot and ankle surgeons. You clearly do that. But I think for us, and if we're trying to brand and grow the profession, we have to reconcile how we use that. The other place where it's kind of hurt us in terms of like recruitment and bringing people into the field, and one of the reasons we did our compensation survey and ACFAS has theirs and things like that, is there's a lot of information out there that is misleading about what you all can make in terms of compensation. One of the reasons is the Bureau of Labor and Statistics uses your guys' tax filings when they're trying to say how much do people make in podiatry. So if you file your taxes and you get to write whatever you want as your occupation, if you write down foot and ankle surgeon, they're not getting counted towards podiatrist. So then when you see that number, which many people will say that number is insanely low, which I agree it is insanely low, it could be because we have people that are identifying as that on their tax forms. And therefore, people don't realize that it's not the same. So I think people should call themselves whatever they want. I think we need to make sure people understand that podiatric medicine means also foot and ankle, that it's not you just what might be the old terminology of what we would call routine foot care, type of stuff. But I do think we have a branding issue if people don't know us as what we are identified on. We are doctors of podiatric medicine. And I think that's a strong title. When I go to see my doctor, I don't say hi, physician. I say, hi, doc. What's up? You guys are doctors. You know what I mean? So I think we need to say that and be proud of it. But I understand why people use the other, so people know what that is. But I think it kind of gives us a little bit of a confusion for the public a little bit when we're not able to kind of get a little bit more behind that. But I'd love to hear your opinion on it as well.
I completely agree. I mean, at the end of the day, people can call themselves whatever they want.
Yeah.
I think historically, the name podiatrist has had potentially, like you said, a somewhat negative connotation in terms of not doing surgery. They're office-based. They're just cut nails all day long, and they don't represent, that name doesn't, in some people's mind, doesn't represent the true scope of all the things that we do. My issue with that is that there's two ways you could approach that. The first is to only call yourself a foot and ankle surgeon, which sounds all well and good because you're avoiding the name podiatrist. But then you're never going to change the perception of the word podiatrist because you've completely abandoned it. Or number two, you can lean into it, absorb that name, become that name, and then show people what you're doing. And eventually the perception of that name will then change. When you call yourself a foot and ankle surgeon, there's ambiguity there between, did you go to podiatry school? Are you a foot and ankle orthopedic surgeon? I have no idea what you're talking about. I don't know what your training is. You're just telling me what you do. And I've made this joke before, but you don't go to the dentist and then some of them call themselves dentists and some of them call themselves tooth and gum surgeons. You're like, wait, are you a tooth and gum surgeon? Well, I'm a dentist, but I'm don't call me dentist. I'm a tooth and gum surgeon. It's like, all right, now I'm just completely confused. And I can't imagine the profession of dentistry ever getting behind that, deciding to be divisive and have two different groups of people who call themselves completely different names. It makes absolutely no sense to me. So I don't care if you want to call yourself a podiatric surgeon or podiatric foot and ankle surgeon. I don't really care. But to lean so far away from the term podiatry doesn't make a whole lot of sense to me. And how are you then going to change the perception of that term over time if you lean so far away from it that the general public has no idea what's happening? That's my thoughts on it.
Yeah. It's a strong thing. We just need to brand it, right? Like it's got to be branded, but people need to understand it. Sometimes I say y'all are the hidden gem, but I don't want you to be hidden. You know what I mean? We got to stand out there in the front and be like, this is what we're doing and this is how well we do it. And just even how I explain it to my own friends and family, right? Like when they say this happened to me and I'm like, here, you want to go to the person who specialized in this day one in school? And has, all these surgeries and all these things, like that is real and we should be proud of it. And we should talk about that work that you all do.
Very much so. Speaking of orthopedic foot and ankle alternatives, and I'm friends with lots of them and maybe not friends with some of the others, but recently their leadership released a statement that was not too in favor of podiatry. We'll put it that way. What does that look like on your side of things when you see something like that released into the public that is blatantly either wrong or feels like it's an attack on the profession? What happens behind the scenes in terms of formulating a coalition or a group or a task force or figuring out who's going to respond, what it's going to say, how do we approach this, all that stuff? What does that look like behind the scenes?
Yeah, so we did put out a letter and we did also send that to the different groups that were involved related to it. So AOFAS, AOA, AMA even.
Oh.
But we have also built relationships with those groups, right? Because even though we have our things that we don't agree on, there's a whole lot more that we are collectively fighting for, physician fee payments, most prior authorization, things like that. But they needed to hear from us that we did not believe this was an accurate representation of the work that you all do. And that, to your point, many of us practice together, in these practices and that we do this work together. So we did get our letter together. We've had face-to-face conversations with their boards and our boards about this is not the way we need to interact with each other. So those are the things we're doing to try to make sure that they understand our position and where we're at with it and how we need to make sure that we're not doing it going forward. I have no problem for us saying, hey, this is the difference between what one does, what the training of one and the training of the other, but let's make sure it's accurate. So
Yeah.
that was kind of where we went with it, is like, okay, we're going to come back and give you the accurate facts, and let's make sure we're sharing the accurate facts and not kind of coloring it one way or another. Are we always going to get like the public apology of something or anything like that? I don't think that that's going to be in the cards oftentimes. The other thing I always also try to like tell ourselves in our profession, that was something that was publicly said, but kind of within a group of people, like the public isn't looking at that stuff too.
Right.
So we have to also measure kind of how big we go, because it could make it even bigger than it needs to be if the reaction to it actually does then get to our patients. I don't think most of that oftentimes is getting to our patients or having real impact to the broader public. It is
Yeah.
infuriating us within our own world because it's inaccurate and not what we want to hear. So I think when you're thinking about the reaction to this, yes, we need to stand firm. We need to talk about what we do. We need to make sure we're reaching out to them and saying that we're not doing these things, and we need to be more collectively working together. And because of some of those relationships, they did say, listen, this is not always where we're standing on this. There's certain people that say certain things, right? But I think we have to make sure that we're being measured. There are times where people look at us and say, why aren't you setting your hair on fire and calling, CNN and Fox News and everybody and saying this is wrong? That would be making it bigger than we need it to be. But I think we have that ability behind the scenes to end up having those conversations. And we've really spent a lot of time, especially like with AMA and others recently, where we don't agree on everything. And we're not always going to agree. But when we do partner on what we do agree on, we do get more done. So we have to figure out that balance.
Yeah, I agree with you. You don't want to make it into a bigger thing that it is, and not to break people's hearts, but people don't care. The general public does not care about this. CNN, Fox News does not care one bit that podiatrists are upset, that orthopedic foot and ankle surgeons said this. Nobody cares, I promise you. They have their own lives. They have their own real world problems, and this is not on the list. To us, it's important.
It's
To us,
huge.
we have to address it. To us, we have to face this head on and have a strong rebuttal to that, and with correcting inaccuracies. But the general public has no care in the world about any of that stuff that's going on. And even if you told them about it, they would still not care about it. So I agree with you. There's no sense in trying to turn it into something bigger than what it is, but just coming back quickly, firmly, saying that's inaccurate. Here's our stance on that. We need to work together. I think that's the most reasonable approach long term, because what I've noticed over time is that the people who share those opinions are, I'll try to word it nicely, they're aging out of the workforce, and the younger people are much more, in my experience of doing this and being on social media, they are much more amiable and likable and interdisciplinary intermingling. And we come to their conferences, they come to ours, we do online meetings together. It's the older group of people that hold on to these thinkings and these outdated thoughts that are eventually going to phase out, maybe probably not go away completely. But I have noticed that it has improved even in my short career of, 10 plus years of doing this since residency. I have noticed a shift in the relationship between DPM and MD-DO side. I don't know. What are your thoughts on that? Have you noticed a shift, or maybe you haven't been around long enough to know?
I think, and I might have heard this on one of your other podcasts I had listened to, but like when you talk to people in practice who are practicing with their MDs and DOs counterparts, it's collegial most of the time. Every now and then you'll get, when we're talking about scope stuff in certain states, you have an association and another association going back and forth with each other. But when you're talking about truly in practice, I don't see that as much what I'm talking to folks. Oftentimes we're practicing in same practices together with some of these people. And so I think everybody recognizes the value. So I've had enough conversations with orthos who are like, yeah, our podiatry counterparts are great. These are the things that they do. Here's how they do this well. We do these things, So I do feel that like sometimes there are people who are never going to be on our side, right? That's just the way the world works. But in my world, sometimes those outside voices get too much attention to what really is happening day to day. And my gut is day to day. I saw the doctor that practices, as you said, with Dr. Dikis, who trains the residencies in his program, the MD, wrote this whole, series about how podiatric, residents are getting taught just exactly the same way. And they're some of the best residents they have. So I think people see that more and that's coming across. We just can't get distracted by those few that might still and continue to be haters in that process, type of thing.
Yeah, and we're so narrowly focused on our profession, but this is not unique to podiatry. There's overlap in neuro versus ortho spine. There's overlap in hand and plastics. There's overlap in any profession. And anytime you introduce dollars, I don't care if we're talking about medicine or foreign policy or the CEO of Amazon versus whoever, you're introducing dollars into the equation. You're going to have people who either disagree or can't get along or are fighting for something because at the end of the day, they're trying to defend based on dollars. And so if there's a group that competes with another group, I think it's ridiculous to expect them to fully get along because that's just not going to happen. But you can be amiable and you can find a way to work together for the greater good, in my mind, versus sending out random letters that are subtly attacking or not so subtly attacking another profession. I find that to be without any class or character.
Well, and I think it's also oftentimes coming from a place of fear. And I just don't choose to want to work from a place of fear. Like, I'd rather work with the people who want to work from a place of collaboration, optimism. How do we move things forward? But you're right. Like, it's fear. What's going to happen to my dollar, my bank account? What's going to happen to so let's work with the people who are not afraid. We're all like, hey, we stand 10 toes down. We know what we do well and we can work together with that. And I think those are the people we want to draw ourselves towards and work with, because I think more of those exist out there than the fear-based kind of things that happen.
Definitely.
We'll be right back after this. For more information, go to podiatrygrowth.com/podpatrol.
So the people have signed up for the 5-email course and 30-minute free conversation with you to analyze where their marketing needs improvement. What steps can they take next?
Yeah, the next step is a deep dive. It's what I call an online practice x-ray. I look into your Google Analytics, your Google Ads. And then the last part of the online practice x-ray is to provide you high ROI marketing plan. It's a really in-depth diagnostic that will give you a clear direction about what those next steps are to help you grow your practice. This is something I generally charge $2,000 for, but since they're Pod Patrol listeners, we're going to chop that in half and charge $1,000 for this diagnostic. You'll have a written document at the end with the competitor analysis, what you're doing now, and a clear marketing plan to make sure that you can be cost effective when it comes to marketing your practice.
Absolutely. I love to hear that. Paw Patrol listeners are getting 50% off from Jim McDaniel, marketing expert at podiatrygrowth.com. If anyone's interested in more information, they can go to podiatrygrowth.com/podpatrol. So you mentioned right before we started recording that you have the House of Delegates coming up. So for anyone who doesn't understand what that is, can you give a brief explanation of what that means?
Sure. So we have a House of Delegates that's truly our governance structure for APMA. And this happens for many professional medical associations. So the American Medical Association has a House of Delegates, the AOA has a House of Delegates, APMA has a House of Delegates, which means once a year, we bring everybody together to say, okay, what are the issues of the day for podiatry? And the way that our house is filled is through our state components. As a part of the state components, you get so many delegates. It's like going to Congress, right? You get so many people and we come in and we talk about the issues of the day related either to APMA, even from a structural perspective, and or issues related to the field and positions we want to take as we move forward. So we're about to hit our deadline for our policy propositions for this year in the next week or so. So once those are done, we'll know that there are policy props, that those are the things that the field wants to talk about and have a conversation about. We are already aware because we've already received one related to ACGME and CPME, and we can talk about that. I know you've talked about it a little bit more. So we know that will be coming back to the House. But it's really, to me, these issues of magnitude that we have to figure out how we have conversations and decide how do we come to a position as a field on how we want to move forward. We might be here now, but what does the future look like for us? So it can be something from like that kind of side of things all the way down to kind of what is our position on what our scope should be, type of things. And so that happens in March. And so we're getting ready for that. And we're looking forward to having our delegates come into town and have those conversations.
So if people are voting, if the delegates are voting,
Okay.
is it a majority? Is it a 60%? How does something get yay or nay?
It depends. So there's different types of things. Some of the things that have larger impact sometimes will require a 2/3 vote for it to pass. These would be like referendums that say like big things about the profession as we move forward. Many of the things only take 50% to
Mhm.
pass, a majority, 51% to pass.
Yeah.
And then our bylaws, some of our bylaws changes take that 2/3, but it depends on what the issue is, if it requires either just a regular majority or kind of a super majority to be able to pass it.
Okay. So let's talk for a minute about ACGME versus CPME. So for anyone younger or who doesn't know what we're talking about, CPME is the current regulator for, well, lots of things, but specifically what we're talking about here is overseeing the residencies, correct?
Yes. The
Podiatric
decision. Yep.
residencies. And I don't know who approached who, but the thought was that does it make sense to have the ACGME, who oversees MD and DO residencies, also oversee the podiatry residencies? Do I have that correct?
Yeah. So there was a reach out from some individuals within podiatry to ACGME, and there was a discussion that was had. Once it was more broadly known, we kind of put a pause on that to say, okay, this is a big issue, right? This is what I'm calling an issue of magnitude. And these are not things you want to take lightly related to that. So we went out and talked to stakeholders from the different podiatric organizations, our state components, the boards. I mean, we talked to lots of folks. And at that time they said, you guys just need to stop. We don't have enough information. And so we had one of our state components then put in a policy proposition that says, okay, let's talk about it then. We don't want to move quickly, but let's talk about it at the House. And so at the House, we're going to have an opportunity to say, okay, do we want to even have these conversations? And I think you have people sitting maybe in 3 different camps, if I was going to try to make it simplified. One who believe that the opportunity, maybe with going with ACGME, might be able to give us to a point where we have better parity with MDs and DOs because we've gone through kind of this same accreditation systems that they have gone through, and that they have different, maybe they're a bigger organization. They might have more things that they can do differently, those type of things. So that's kind of, I think, one set of folks that are interested in ACGME. There's another set that are not interested in the conversation at all because they believe that CPME is doing a good job, which they are. They're part of us. CPME does a good job. But that we want to manage our own world and that we want to make sure that it's podiatric centric and we don't necessarily want to get pulled into a world with the MDs and DOs that we might not be able to control at all. And then there's another group of people that say, we don't know enough information to make any decision about this yet, because what we have right now is the best is rumor and speculation because we haven't had the conversation yet. So there's another group of people that say, I don't know what I think about this, but maybe we should at least talk about it. And what does talking about it mean? Like, what data would we need to know? What are maybe some of the non-starters? Like, if we were going to get into these conversations, meaning if we got in right away and they were like, this is nothing, we don't have any interest in parity, this is just a business decision for us, would we be even interested in it? So I think at the House, you're going to hear the conversation from those different groups to say, is there value in the discussion or not? Or are we happy where we're at? And I don't have the answer to that. And I don't have an opinion yet on it. But I do think the good thing that we will be doing is having the discussion about it, right? And when you're talking about issues of magnitude, like this, they shouldn't move super quick. Because if you make big decisions like this without the right data and without the right information, we can make the wrong decision. And I'm not sure we even know what we want. Is the end goal parity? I don't know. We haven't had that conversation. Is the end goal something else? Is the end goal, to stay autonomous? We need to figure out what our goal would be, even if we wanted to do that. And so I think that's going to be the opportunity that comes up at the House to start to talk about it. And I think we might be able to use this for other big issues that come up. Like, how do we go about processing these things? Because in the past, we would kind of just throw barbs at each other and then see who won, and that's not really helpful. So I think if we can figure out a way to say, okay, what data do we need to make these decisions? How do we talk to all the stakeholders? How do we look at what the future needs versus what we need now? So I think that this is going to be a really nice, robust conversation to figure out how we talk about these things.
Yeah, I completely agree with you. I think it's important to take a step back and get more information before anybody makes a decision. You're always going to have people who are steadfast or in their opinions based on their camp that they come from. My 2 cents, not that anyone asked for it, but it could be a slippery slope there if you involve the ACGME. If you hand the keys of the profession, which in order to become a profession, you have to go through a few criteria. We all know you have to go to the schools have to be regulated, and then you have to graduate, and then you have to go to residency, and residencies have to be accredited, and you have to graduate through residency. So in order to have a profession, that is one of the significant building blocks that get you through from point A to point B. And you kind of don't know what you're getting on the other side with ACGME. If there's, in my mind, ACGME also encompasses orthopedics. And weren't we just at battle with orthopedics in terms of them sending this nasty letter and telling us that we're not equivalent to them? And then if we hand the keys over to them to accredit our residencies, are they going to do something that we wish that we wouldn't have done? So again, it goes back to getting more information there before we figure out what that means.
Right.
So I think it's tricky, but if you're doing it just for parity, I've always struggled with that. Like, I don't know why some people are so caught up in parity. Like, we want parity. Like, why don't you just show up, do a good job, go to work, have good outcomes for your patients, and go home? Why do you care so much about what other people think? I've never understood that. And I think that the people who believe that ACGME will give them parity, I think that's a pipe dream. I think that if magically you think that MDs or DOs who don't like podiatry, however few that may be, because I don't actually interact with hardly any of them. All of my other partners even in orthopedics, my orthopedic partners right down the hall, but in general surgery and family practice and all the other people who I interact with love us and love what we do. But if you think that magically those people who don't like you are then going to turn around and be like, oh yeah, okay, now you're great. Now we love you. I just don't see that happening. So I think a couple of things. I don't get a vote, number one, so it doesn't matter what I think. Number two, you're going to be in for a really, really long conversation that day. So I'll be thinking about you, because I've been stuck in meetings before where everyone's talking and everyone wants to hear themselves talk and everyone thinks their opinion is the most important. And I'm just sitting there rubbing my temples, wishing it would end. So I think you're in for a long meeting on that one.
Well, we want to make sure we have a robust conversation because we do want to hear from everybody. The upside is we also have, the rules of parliamentarianism. So there is, at some point we can say we've said it all, right? And it's time to move to a vote. But I do think it's interesting and part of the conversation about parity, which is not just an ACGME conversation. This is a conversation we have as part of podiatry all the time. Since we talk about it so much, I went back and read the definition of parity again, just to say, what does parity mean, definitionally? And the two aspects of it are pay and status, right? So from a parity perspective, what do we want from a pay parity? And I think in a lot of areas, as we are seeing, we do have a lot of pay parity in certain areas already, maybe not in everything. Like on-call pay is a problem for us that we need to tackle differently. And we have some ideas on that. But status is the one that's hard. I think it's getting at what you're saying, which is status can both be how other people see you or how you see yourself too. And so if you're within a system where your peers see you that way and you see yourself that way, the status doesn't seem like that big of a deal. If you're in an environment where that might not be true, then status in that area becomes much more important. Yeah, I think it's a good question to have about what do we mean by it and how do we move forward from it. But I do think knowing more about what people want and then asking the right questions, then we can decide if something's the right fit for us. And if it's not, we got a good system working, right? So then
Yeah.
we don't have to do anything we don't want to do. But I also think talking about ideas shouldn't be scary either, even if we don't agree with it. So let's find a way to have the idea conversation without getting, as much of the, because we have the discussion, it means it'll end up one way or another. We don't know how it's going to end up at this point. So,
Yeah, I agree with you. I can guarantee you 0 of the doctors that I work with, I'm talking about non-DPM, 0 of the doctors, if I went up to all of the doctors I've ever met and I said, quick, what organization certifies the podiatry residencies? They would have no clue whether it was this acronym or this so it's like, if we change that, I'm going to walk up to all those same doctors and I'm going to be like, hey, it's different now, did you hear about it? And they're going to be like, no, I don't care. You showed up, you took care of the patients, you did a good surgery, your patients love you, you have good reviews, we're happy to have you here. So I mean, yes, it matters, but like at the grand scheme of other doctors and what they think of you, I don't think your accrediting body of your residencies is what other physicians think of you. My colleagues think of me as, hey, he's nice, or he gets patients in on time when I call and say, hey, can you add on this ingrown nail? You bent over backwards to squeeze them in. I really appreciate that. Those are the things that build collegiality in the interdisciplinary other physicians, more so than the accrediting body of the residencies. Again, I'm not saying it doesn't matter. I'm saying some people, I think, interpret this a little bit in a weird way, and somehow they think, oh, now we're going to be thought of this way. And I guarantee you, none of those other doctors care, and nor should they, what the accrediting body of podiatry residencies is or might be.
Might be some upsides. I mean, that's the point of deciding if we want to have the conversation. I just don't think we know enough of the up or the downs. And I think we have some assumptions about what they are. But if we want to pursue it, we're going to have to go have some conversations. So that's what the House is going to decide. Do we want to even have the conversations? And then we can decide the pros and cons and if it's worth doing or not doing and go from there. So you're right. It's going to be a fun discussion, but we're going to get through it like we do on everything else. And I think we're going to come back at least with people feeling heard. And a lot of times that's what it's about. Like if you're part of the process and you've been heard, even if it doesn't necessarily go the way you want it to go, at least you feel like it was fair, right? These type of things do. That's what the House does. So we can come in and have these discussions and make a decision. And it may land the way you want or it may not, but at least we feel like it's been vetted in the right way.
100% agree. I think it's all about gathering the information first, figuring out what makes the most sense and going in that direction. So recently, there was a salary survey. I don't know how to broach this topic. Was it an APMA idea? Because then ACFAS decided to do their own survey. But at some point, someone decided that we should get a true estimate, or a true, as close to possible estimate of what the average salary for a podiatrist in the United States is this currently. And that data is now available. So do you want to talk about that a little bit? What was the genesis of starting this process in the first place, why it came to be, and what the results of that salary survey are?
Sure. So there was the ACFAS does their survey, I think every 2 or 3 years. PJ, don't kill me if I have that wrong, but they do theirs every so often. And theirs came out, I think, in September or October. And that's just for the people that are members of ACFAS and ABFAS certified. Our survey we did in conjunction with Merit Health. And what we wanted to do is to make sure that we had the whole breadth of podiatry, not just necessarily people that are ACFAS or ABFAS certified, but like the whole breadth of it. So I think they ended up having about 900 and they had their data that came out. We were able to get 1,300 podiatrists to complete the information through Merit Health. And part of what we were trying to do is get a statistically significant survey. So we have this wonderful gentleman on our team who's our director of strategic analytics, who knows all the numbers to say, if you're within a 95% confidence rating of statistical significance, we can say within 10 grand that the numbers are accurate. We got that with the numbers that we got. And so what we did is kind of drill down into that. So the numbers you'll see from both of the organizations are different, but I think it's because there's a different there's a broader group maybe that we're getting versus the group that ACFAS is doing, but they're both good data points to be able to have. So through that survey, we found that the median salary for podiatrists is $260, or the mean is $300,000 a year. But what it found in all the surveys we do have a very wide range in podiatry. And it does come back to, like, some people practice differently. It changes based on where part of the country you're in necessarily. It's regionality. If it's your hospital-based, office-based, those type of things, I think are coming into play. So we have a really comprehensive survey that dug down into that. I think it's 33 pages long if everybody wants to read it all. But the reason we were doing it for a couple is to be able to have the data to be able to advocate where we need to. So ways that we wanted to be able to use this, we want to use it for student recruitment, because we think the data that is out there is inaccurate and too low. So we're going to be using it and creating a document for all of our schools to be able to use for students. So that when people come to their website and they see these other things, that they have a document that truly shows that this is statistically accurate and related to it. We also want to be able to use it for our podiatric physicians. So we're going to be launching a series of webinars in the coming months where people can use it when you're going in to have conversations with people. So if you're going in to do negotiations with your hospital or with your group or whatever, you have data now that you can say, okay, here's where the averages are. This isn't aligned with what our region's doing. We also did a lot of work to make sure we had statistical significant by region, not just overall, so that we could say this is a good number for the West Coast or for the Northeast related to that. So we're going to do some webinars so that, especially for the young physicians that are coming out and trying to figure out, like, is this fair? Or am I in the right range related to some of this stuff? That they can have that information. It has information about RVUs, benefits, on-call pay. It's stuff that you all can use when you're going in to have those conversations to be able to do that and do that well with one another. So I think there was multiple reasons for us. And it also showed us some demographic changes that are happening. So in our survey, we were surprised to see that over the last 5 years, we've had we knew it, but to see the numbers, a significant shift from people who are owners of their own practices to group practices or hospital employee practices. That used to be closer to 60%. It's now 17% of people are they're the owner of their practice. That means a lot for us. Like, what does that mean for us as a profession? How does that change how we advocate? If we're advocating for some, and it means we still have to advocate for everybody, but it tells you kind of where the work is moving for some people, and it might shift back over time. So it gives us a lot of that information to be able to make sure we're meeting our members where they are, so that we can provide the best value for them. Because having come from the hospital, if you're a hospital-based podiatric physician, you have different needs than if you're in a private practice by yourself and doing work differently.
Yeah, I think it's been very helpful, and I found the survey results very interesting. Obviously, there's going to be geographical differences. I hope you make more money if you live in New York City or Boston and San Francisco, just because the cost of living is so much different. So there's going to be variability geographically. But one of the interesting things is, I've said it before on the podcast, I work 24 hours a week, and there are a lot of people that work 40. So it's hard to compare my salary at 24 hours a week to a salary of someone working 40 or 50 or 60. So that kind of I noticed that would throw things off a little bit. I don't know if it's worth it to go back in and figure out $1 per hour to equilibrate those, or if it even matters at that point, because at least then it would be apples to apples as opposed to comparing different hours per week salaries. But I found the information to be extremely helpful and encouraging, because I know lots and lots of podiatrists. Obviously, most people listening to the podcast also do know other podiatrists, but we'll talk salary. And I know there's lots of people making a ton of money. And then you get on some of these websites that for whatever reason, like to badmouth podiatry and say you don't make any money and you can't support your family and all these things. I'm like, where's this coming from? Like, that doesn't make any sense. That's not my real world experience. People I'm talking to, they're giving me, oh, I signed a contract for this, or my RV dollar amount is this, or I just got to buy into my orthopedic group for this amount of dollars, and here's the revenue generated, or here's my surgery center buy-in. And that's the other thing that I don't think, well, actually, I'm not sure if that salary included surgery center ancillaries and all the other
ancillary income in there too. And that's part of the reason, because podiatrists are great with side hustles and the other things that they do related to things. So I think that's part of the other reason why you have this huge, gap between some of the numbers related to it.
Yeah.
But we're going to continue to modify the survey over time, because we figured out places where, we could drill in a little bit more here so that we can find out more. So we're probably going to be doing updates like almost every 6 months now at this point, to be able to kind of okay, we found out this. How do we find out more to be able to figure that out? So yeah, I do think, and I would agree with you, I don't like the message boards and the negativity that's related to those things, because I don't think it speaks for the whole profession. I do think it's a true feeling for certain people, but I don't think it's the broader people. And oftentimes the people that are doing well aren't spending time on the message boards and doing those type of things. So I think
100% agree. That's what I've said too. The people successful don't have time to be on the message boards complaining about why they aren't successful. We're out being successful.
So I think it gives just the real data. And that's why I love, Sam on our team so much, because if you want to go to the end, you can see every statistical method we use that is solid. You know what I mean? This isn't just, random surveying type techniques. So I think it really does give us a good foot to stand on related to it. But there's more to do, and there's more for us to do as a profession. I mean, both the ACFAS and the APMA survey showed a big gender gap in pay. Women are still getting paid much less than men in these areas. So there's ways that we can look at this in a lot of different ways that can help people look at this differently. So I'm excited. And there'll be more to come. If people have ideas, please reach out and tell us, hey, you didn't get this right, or because we will be iterating this. But I think we have pretty strong footing to start with right now.
Just as an aside, because I think it's interesting and is related to this topic, is starting this month, I'm starting to go to a new hospital, an outreach hospital. And the way that they are paying me is, what they did is that all of us are going, my general surgery colleagues and my orthopedic colleague, we're all going to this hospital as outreach. And what they did, the hospital came back and they said, here's the MGAMA number for podiatry, ortho, gen surg. Here's how much we're going to pay you flat fee per day. So to think that this aggregation of data and salary and information doesn't matter is false, because there are people who are going to get reimbursed based on the MGMA data, or data that's out there that supports, here's the average salary for a podiatrist in the United States of America. So this data is very important. And if the average is a lot higher than what people thought that it was, well, then maybe the next time you go to negotiate your contract, you go and you pull this data and you say, hey, here's the average, and it's a bargaining tool for you to be able to utilize when you are signing a new contract. So I think there is a lot of inherent value, not just curiosity, I wonder how much people are making in this city, but actually using that on a daily basis to be able to go to war, bad terminology, to collegially agree upon a set salary of your new contract.
Yeah, no, I think it's true. I think it'll be able to be used in a lot of areas related to that. And like I said, having been on the hospital side of it, they're going to go with data, and the MGMA stuff, it doesn't have enough people. It's just not as accurate as we need it to be able to do the work we need to do. So we're hoping it'll be helpful for folks to be able to use.
What do you want podiatrists to know about APMA? Anyone listening, what do you want them to know about APMA?
Well, the first thing we've been talking about is it's a new day at APMA, meaning we're doing things differently. We're doing things at, I think, a more forward-thinking manner, that we're really trying to figure out how we can meet podiatrists where they are. But if I was going to come down to a couple of things that I want to make sure everybody knows about it, is we're here for you, right? So if you're not seeing what you need, or if you're having problems, yesterday, our president, Dr. Brooke Bisbee, signed a letter to help somebody with some credentialing issues they were having with a hospital, right? We can get down to even that level to help you to say, we can give you resources. We're going down to Mississippi this next month for their legislative day because they don't have ankle in Mississippi. And we're looking at ways that we can get scope expanded in Mississippi because they need that care down there. We truly are here to help you with what you need changes for, even from a personal level, all the way up to the macro things that we do for an advocacy perspective. So if you need help and you need, kind of resources, even if we don't do it specifically ourselves, we're connected to everything to be able to do that. So being a member creates that community for you. It gives your ability. I think more people in podiatry has my cell phone number than my cell phone is, everybody can have it. We are here to help. We are here to make sure that we're doing what we need to be able to help you. So be a part of the team, get involved with us because we can help you do that. And the only way that we know to help you is if you're part of that, right? So get on our committees, reach out to us, talk to us. When I started, everybody was laughing at me because I called every person who had something negative to say about APMA. And I will tell you, I got most of those people to come become members because you need to hear why people are not happy, because there are things we need to do differently. If we're not changing and evolving to help you all do what you need to do, then we need to do that. So we're going to be putting out new programming for those folks that are hospital-based practices. We are hearing from our younger physicians, I want to learn how to be a chief of staff maybe one day. Are we getting them ready for that? Should be doing leadership training? How can we get our members ready for that? How is that available for them? In terms of tech and innovation, AI is coming. Are we ready for that? APMA wants to have those tools and resources for you so that you don't have to figure this all out by yourself. So I think it's really just having, to your point earlier, kind of that, not only the backstop to defend, but really the tool chest that you might need to be able to do the different things. And then when you're kind of at a loss of like, how do I go next? We're there to help you figure out the way that you can do that. And we work so closely with all our other groups. I think, be part of sports medicine if you're part of sports medicine. Be part of ACFAS. Be part of these organizations. We're all working for the same things. But when you're part of APMA, that is the advocacy that helps you get those payments you need, helps to make sure that you can continue to practice the way that you want to practice, to make sure that you can get that care to your patients and you have access to them. So, come in, be a part. I think there's a lot of tools in our tool chest that then become your tool chest that you can use and be a part of.
Absolutely. Very well said. I completely agree. And the unsung hero of the profession, working behind the scenes, that takes care of us without us even knowing that you're taking care of us. So thank you so much for your time and joining me tonight. I really appreciated our conversation.
Thank you. This was great. I hope to talk to you soon. And I'm sure I'll see you out and about at all the conferences at some points.
Absolutely. I'll be there.
All right.
Thank you so much. Thanks to everyone for listening to this episode of Paw Patrol with your host, Dr. Jeff Dikis, joined by CEO of APMA, Megan McClellan. Thank you for joining us. We'll see you guys next time.
Thank you.
Paw Patrol. Paw Patrol. Paw Patrol.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.